Hi, my name is Melanie Bell, and I will be presenting this Congestive Heart Failure, Reducing Readmissions Through Patient Education webinar in partial fulfillment of my Nursing Informatics course for University of Texas at Arlington. The purpose of this webinar is to improve outcomes related to heart failure admissions by enhancing patient education through nursing awareness and engagement. An overview of this course is first that we will discuss the impact of heart failure. Then we will discuss inpatient focus. Education strategies will be covered, as well as self-management topics for the patient, and outpatient follow-up. Why is heart failure so important? Well, first of all, the cost of heart failure to the U.S. government is tremendous. The CDC estimates that we've spent $39 billion on heart failure medical costs in 2010, and $17 billion of that was in avoidable readmissions. About 18.1% of heart failure patients are readmitted within 15 days of discharge, and 85% of these are avoidable. Also, there have been recent changes in healthcare reimbursement through the Center for Medicare and Medicaid, and hospitals will no longer receive reimbursement for readmissions within 30 days. Also, these readmissions are going to be tracked as an indicator of quality, and pay for performance will start impacting reimbursement as well. As far as inpatient nursing focus, we have these patients for a short period of time, so we need to identify their risk level. Parkland has actually developed a risk tool that is able to identify the top 20% high-risk patients that result in the 60% of readmissions. So this risk tool is being utilized at Parkland, and it's also being trialed at another large hospital system in the Dallas area. And so it will hopefully be available on a wider scale sometime in the next year or so. So just being able to identify who it is that you need to spend extra time with, who it is that's more likely to be back in another week or two, gives you the opportunity to really selectively target patients for more frequent follow-up, more detailed education, identifying resources at home for them. And then, of course, focusing on early assessment and self-management of the disease is essential. Early assessment while they're inpatient means that not only are you as the nurse identifying things like shortness of breath or fluid status, but you're explaining these things to them as you were assessing for them. So the patient may have a history of heart failure but not be there for a current exacerbation. But it's still essential that we're doing things like daily weights and looking for edema and that type of thing, and explaining that to the patient so they understand and can continue to do their own self-assessments at home. Also, these teachings should start at the time of admission and continue all the way to the time of discharge. It's essential that these patients be given as much information as they can during the short stay that they are in the hospital. It's also essential that all of our inpatient nurses have a high awareness of outpatient resources as well. We need to be able to send these patients home with information on support groups and follow-up education and resources that they can utilize if they have questions when they get home. We have them for a very small amount of time, and there's no way possible for us to convey all of the information necessary during one admission. So give them these opportunities for additional education. As far as education strategies are concerned, first of all, you want to individualize all of your education. You want to identify what your patient's base knowledge is, and then build off that information. You may be able to get more information, more detailed and more complex information to a patient that already has a good understanding of the anatomy and physiology of their disease than you would maybe a new onset patient that has no idea what heart failure is. You may be doing good just to make them understand what their disease process looks like. You also want to identify any barriers to education that they have. Is there a language issue? Do they have a hearing difficulty? Do they have any difficulties in reading, and how can you overcome those barriers? And then learning styles themselves. Different people learn in different ways, and we need to be conscious of that while we're providing this education. And in order to accommodate those learning styles, we need to have different types of education available. Do you have a video at your hospital that can be provided, even if it's a matter of rolling a television into the room and playing a DVD, or maybe they have portable DVDs at your hospital. And then I know some of the hospitals have the on-demand patient education services. And then our old tried and true written information is great, but you also should be covering it verbally with your patients. Maybe provide them the written information and ask them to review it, and then go back later and discuss it with them. Make sure that they have a clear understanding of the information that you provided to them. And then spread that out during the hospitalization. Don't expect to go in with a 20-page packet and cover all of that with the patient on that day. Say, why don't you read pages 1 through 4, and I'm going to come back in a couple of hours when I have a few minutes, and I want to discuss that information with you and see if you have any questions. You can also utilize a heart failure education record, and if you don't have one of these, work with your education department or work with your unit manager to develop something like this, because that allows some continuity in education for these patients, so that you can spread out that information but know that the patient got all of it by the time of discharge. So identify the main categories that need to be discussed, and then everybody take 1 or 2 of those each day and discuss them with the patient. And the topics that we need to cover while these patients are inpatient, and these are in addition to just the general anatomy and physiology and an understanding of what heart failure is. We also need to discuss with them smoking cessation. If they are still an active smoker, it is essential that they stop smoking, because smoking will continue to debilitate them and cause problems with their disease. Symptom tracking is a major thing in heart failure these days. They need to understand their symptoms, number one, what symptoms are related to heart failure. And then they need to track daily their severity. What was their shortness of breath on a scale of 1 to 5 on this day, or their cough, their edema, their fatigue. They also need to weigh themselves daily, and this means they have to have a scale at home. And if they don't, work with your hospital to develop a scale program where you can send these patients home with a scale. It's about a $7 investment on the hospital's part, but it may save them a large amount of money when they're saving $8,000 or $10,000 on a readmission. Also, activity and energy conservation is such a difficult thing for heart failure patients. They need to understand that, yes, we want them to be active, and we want them, if they are overweight, we want them to try to lose weight. But at the same time, they have to do so in a way that is compatible with their heart failure. If they overdo it, that tends to throw them into exacerbations. So it's important that they have light activities intermingled with rest. They also need to understand their diet and the importance of a cardiac diet, including low sodium and potentially even fluid restrictions. And maybe provide them with a list of high sodium foods, things like canned soups and frozen dinners, convenience foods and sports drinks. Teach them how to read a food label. They need to understand they should never eat something that has more than 200 milligrams of salt per serving. And then they also understand when they need to contact the doctor. When they call, they need to let the receptionist know the answers. I'm a heart failure patient, and I need to get in to see the doctor as soon as possible because I've gained 4 pounds in the last 2 days, and I'm swelling and I'm short of breath. A lot of the doctors today are overwhelmed, our family practitioners and internal medicine doctors, with patient loads, and oftentimes you can't get in to see them for 3 to 5 days, and I've even heard up to 2 weeks, and that's not an option with these heart failure patients. They will end up in the hospital again before they are seen outpatient if they are allowed to go that far out. So most doctors now, if you tell them you're a heart failure patient, they are able to get you in much more quickly. As far as the types of outpatient follow-up that are currently available, and you need to identify what opportunities there are both that are existing at your facility, and maybe some opportunities for some expansion, and make some offers to your administration and your board about things that they could do to improve readmissions. But some facilities do have heart failure clinics. Now, these clinics typically will see patients after discharge, and they'll try to prevent readmissions. They do have a large upfront investment, but they are proven to make a big impact on readmission rates. There's also a new coach model that's being developed and is currently being trialed across the nation that involves a registered nurse or two, depending on the size of the hospital, and I'm sure even more than that, that will follow up with patients both on the phone and with a home visit after discharge. The nice thing about this is it doesn't require an office space like a clinic does, but it has very, very good results. These nurses are able to go into these people's homes and assess them and provide a physician referral for treatment if necessary. There's also home health available, and many home health now has electronic monitoring or RN visits. They have a specialized heart failure plan. So work with your case management groups to determine what home health agencies provide the electronic monitoring or who has a specialized heart failure plan, and make sure that these patients are going home with one of those agencies preferably. And the most simple thing that actually can have a huge impact on your readmission rate and requires no investment as far as monetary, it's just a change in process, is for the nurse to go ahead and schedule the patient's follow-up visit prior to discharge. So, doctor says they really should be seen within 2 to 3 days of discharge on a heart failure patient. Go ahead and call and make that appointment for them. So it is set up and there's no question about it, and you just provide them with the information and tell them to show up. That way there's nothing slipping through the cracks. We don't have a patient that calls and maybe is kind of a passive personality and has the receptionist say, oh, well, we have an appointment and next Thursday, and this is on Tuesday, and that patient ends up back in the hospital at the beginning of the next week because they haven't been seen. So these are the references that I've utilized for this PowerPoint and webcast. I appreciate your attention. Heart failure is an ongoing problem in the United States, and I think that nurses can make a large impact on the readmission rates as well as the long-term outcomes for these patients. So I appreciate your time, and please contact me if you have any questions.